So should I try it now?
I'm now on your very first page, but with all the slides at the side.
Yeah, has it gone on? No. I don't think it's going to work. This is what I did last time. It didn't work. Oh, it's broken now. Yeah.
Have you got the similar thing as before where your answers come up?
Well, I did like do it not so much like that, so just in case this happened again.
Yeah.
But yeah.
Chat friendly page. So I've saved that one and I'm sending it to you now.
Okay, how's that? Is that working?
No, I'm still on your main page.
So that's just basically the same. Well, at least let's make these go away. I don't know if you can hear like screaming children in the background. They're not my children. I have no control over these children. I'm wondering, like, oh, sorry, if I share the slides, but no, it just says it in PDF, so that's not going to be any better, really. We'll try just doing the whole screen and see if that. Oh my gosh, look at that! Crazy. No, don't need to see that.
Yeah, this is.
Does that work better? Do you think?
Yes.
Now it's like on a proper slideshow.
Yes, it is.
Okay, perfect. I feel like that was how that was so hard. I don't know. Okay, so you sent me something as well. So yes, I have the chat as well. Lovely. Okay, so pleased.
We'll start in about 2 minutes if that's okay, Helen.
Yeah. Are these children very, very loud? I could shut the door. It's very hot. But I don't mind. I can do that if you think it's better. Okay, I'll do that.
All right. Hello, good evening, everyone. Welcome to Mind the Bleed Ops and Gynae's final series. We've got Dr. Helen Parry here. Some of you may have attended her previous session on early pregnancy, and I think we all found that really useful. So we've got Dr. Helen Parry again here to talk to us about red flags in pregnancy, especially for non-obstetricians. It'll be really useful. So thank you very much for coming here to speak with us, and you can take it away. Thank you.
Okay, thank you, Divya. So my name is Helen. I'm ST3 Ops and Gynae trainee at Wigan at the moment. This presentation is mostly for people who are non-obstetricians, hence the title. So these are the kind of pregnant women you might see in A&E or in GP, and that might have basically things to look out for in pregnant women if you see them in A&E or in GP. So I'm mostly going to focus on so some things are really obvious. Obviously, if someone's having PV bleeding or, abdominal pain, these are obvious. You would refer those to obstetrics. So I'm trying to think a bit more outside the box about other things that we might be interested in hearing about that maybe don't on first glance seem like they would be obstetric or we would be interested. So that's kind of what I'm going to focus on, if that's all right. So I'm going to do mostly cases. If people can put things in the chat, that's really helpful. But, I appreciate it's very hot, so you can just listen if you like, it's fine. So first case, all of these cases are real cases, by the way, as well. So first case, so she is a 25-year-old. It's her first pregnancy. She's a low-risk pregnancy, only been seeing the midwife. She's had the normal scans that she'd have at 12 weeks and 20 weeks, but otherwise she's just totally seen the midwife. She's 29 weeks and 1 day. And in terms of her background, she's normally a fit and well young lady. She's got a normal BMI, no other concerns at all. So she comes to A&E with chest pain. So what are we thinking, or what do we need to rule out or think about if we see someone with chest pain who's pregnant, or a young person with chest pain in general, I suppose? Just wait for the chat, see if any ideas. Yeah, I'm getting a few things. So yeah, PE, yeah, I think quite a few people saying that, which yeah, definitely, that's definitely a good one. Anxiety as well, yes. A lot of young women come with anxiety, especially pregnant young women as well. So that's another good one. Yeah, ruling out myocardial infarction, ACS, that's often overlooked, especially in young women, I think. But it is important if someone has chest pain, obviously, to do an ECG, just in case, you never know. Yeah, someone else said angina, so yeah, like ACS type pictures, yeah. So I think that's like the main things we're going to be thinking about, basically. I would agree with that, really. Yeah, and acid reflux, someone said as well, so yeah. Pretty much that covers the most likely things that you're going to see in a young woman, especially a young pregnant woman in A&E. PE, anxiety and acid reflux, and then yeah, rule out just cardiac problems as well. So what happened? So this is just a bit more history. I guess you'd want to take more history to get your differentials down a little bit more. She didn't have any shortness of breath or any palpitations. She didn't have any other symptoms at all. No obstetric symptoms, essentially, is what I'm getting at with that. No abdo pain, no PV bleeding. Baby's moving normally. When she was examined, that was all fine. No, nothing standing out. A new score was 0. So yeah, it's kind of following on from your differentials. I don't think we've really shortened our list of differentials that much, and potentially slightly less likely to be ACS and things like that. But apart from that, it's kind of not really ruled out anything. So what kind of next investigations and things might we want to do for this lady? Yeah, ECG. Yeah, no, not D-dimer. I'm going to come to that, but anyway. Yeah, bloods. Yeah. Yeah, that is another good one to think of. Actually, I share yes. Sometimes if they have if they're very anemic, they may get chest pain. I have seen patients like that before. Yeah, could do an echo, yeah. Not normally transthoracic, but you could do an echo. Fine, so we'll move on. So yeah, it's usual chest pain stuff, basically. So she had bloods done, which were all normal, including troponin. Everything was normal. ECG was normal. And she had a chest x-ray as well, because she was going down a PE pathway, essentially. And that was also normal. So yeah, what next? The A&E doctor essentially was going down the PE route. That's what they thought it was, which is completely fair enough, considering how she presented. So she had a CTPA. So this is my note here. D-dimers don't do D-dimer in a pregnant patient. They will definitely be raised, so there's no point in doing that. Also, essentially, all pregnant women are high risk for VTE, so you don't really need to do a well score. You don't really need a D-dimer because you already know that the patient is high risk, and so if you suspect a PE, you need to do a scan. You need to rule out PE, essentially. Same with the DVT. If you suspect it, you need to just do the scan. There's no point doing these in-between things that try to risk stratify because they're already high risk. So you're wasting your time doing well score and things like that. So basically, there's no point doing a D-dimer. Often they do get done by A&E. I think just when they come through the door, there's just like a chest pain set of bloods that get done by the nurses or whoever does the bloods. So often we do get discussions about D-dimer, but you don't think to do a D-dimer. If it's not been done, don't bother, basically. Because yeah, it will be raised, but it doesn't tell you anything. It's raised in pregnancy anyway, so it is no help at all. So the CTPA on this lady was negative. So because the CTPA was negative, they said, oh, it's probably heartburn. Because when you actually heard her story, the chest pain was more upper, like epigastric, lower chest kind of area. So they said, oh, it's probably just heartburn because you're pregnant. So here's some omeprazole, which is fair enough. It is fair enough. I probably think if they were very thorough and they did a CTPA, and if that was negative, I think it is fair enough to say it's probably heartburn or it's probably muscular. That's completely fair. What happened so they safety netted her to come back, obviously, if anything got worse. So she did come back 2 days later as the pain was still there. It was actually a bit worse than it was before. Again, her new score was 0 and her examination was unremarkable, no real change. ECG was done again and bloods were done again, and they're both normal again. However, this time a patient says, oh, actually the baby hasn't been moving as much as normal. So after they'd finished assessing her in A&E, they just referred her up to maternity triage, basically just to check on the baby, really, more than anything else. So she came up to the maternity triage. When she got there, so she had a CTG, which was normal. No, that was fine. But this was her blood pressure, and she had 4 plus of protein in her urine. And of note, when you actually look back, her blood pressure was this all the time. It was always this, the other times that she came as well. And she hadn't had a urine dip done in A&E those other times that she came. So she had this ongoing chest pain and epigastric pain. Abdomen was soft, non-tender, really. When you checked her reflexes, they were brisk, and she had 4 beats of clonus. So I don't know if anyone has done any obstetrics or anything or remembers from med school, but what's the diagnosis here? Yeah, preeclampsia. Yeah. And this is an unusual presentation of preeclampsia, so I'll give you that, and I'll give A&E that. It's completely fair that it wasn't obvious. Usually a preeclampsia will present with a headache or with no real symptoms, to be honest, visual disturbance sometimes, but sometimes it can present just with epigastric pain, and that is what happened to this lady. So just a few slides about preeclampsia. Obviously, as non-obstetricians, you're not really going to be managing it that much, but it is the kind of thing that can be found as it was for this lady. So it's kind of worth knowing a little tiny bit about it. So what preeclampsia is so it's hypertension, and in pregnancy, hypertension is defined as above 140/90. So this is where it all went wrong in A&E, if you like, because, on a normal non-pregnant patient, no one would even think about that blood pressure. That is not bad, really, whatever. You wouldn't even care about that at all, especially in a young person. You'd just be like, okay, fine, whatever. So yeah, you have to have hypertension and be pregnant, obviously. And proteinuria, so more than 1+, and be more than 20 weeks. So sometimes I do get phone calls about women who are like, 12 weeks with these symptoms, and I'm like, well, no, it's not preeclampsia. It cannot be preeclampsia less than 20 weeks. But preeclampsia is actually very unusual, less than 28 weeks. It can happen less than 28 weeks. We do see it, but these are very, very severe preeclampsias. The majority of preeclampsias will present later than 28 weeks, generally. Right. So we don't really know what preeclampsia is, to be honest, but basically it seems to be associated with suboptimal uteroplacental perfusion. And when that placenta is not embedded properly, essentially, into the uterus, there's like this maternal inflammatory response and maternal vascular endothelial dysfunction. So that's kind of what leads to the hypertension, to the proteinuria. They're just leaky kind of from everywhere, really. So that's why a lot of the symptoms that they get and a lot of the complications that they get are based on that. Can affect any organ system. And essentially, the placenta definitely has a pivotal role, because we know that once we deliver the placenta, preeclampsia resolves, essentially. Not immediately, but over a few days, it resolves. So, potential complications. So preeclampsia is very serious. I mean, a lot of the time we catch it very early these days because everybody is so hot on it, especially midwives. Very, very, they refer them in with blood pressure very frequently. So we don't tend to get to the complications side that much, but the potential complications if it's undiagnosed and not treated. So you can have eclampsia. I mean, that's the outcome of preeclampsia, basically. Eclampsia is a fit, essentially. The high blood pressure itself can cause a stroke or cerebral hemorrhage. They can get pulmonary edema, so as I was saying again, with the leaky from everywhere. You can get HELLP syndrome. They can go into renal failure. And thinking about the baby can not grow as we expect. And in an acute situation, if it's a small baby and if you have very high blood pressure, you can have things like a placental abruption or leading to fetal distress, things like that, and a lot of other serious complications like that. So, preeclampsia, it's a serious diagnosis, but the vast majority of preeclamptic ladies can be managed as outpatients once we've controlled their blood pressure. But it really depends on the severity. As I said before, the earlier you get preeclampsia, the more severe it tends to be. So if you get very early preeclampsia, you tend to be quite severe and not really outpatient suitable. But if you get later in the pregnancy, it can be a bit more mild and you can get to like term, 37 weeks, things like that. It kind of just depends. And sometimes it kind of creeps up kind of slowly. and we can manage it by, keeping the blood pressure under control. So these are the antihypertensives that we use in pregnancy. Basically, labetalol is first line, unless they're asthmatic, and then they have nifedipine. So we can give labetalol up to 300 4 times a day. And we can also add in nifedipine as well, which they can have 30 twice a day. So the very severe preeclamptics will be on that full maximum. Generally, we don't really use methyl dopa anymore. If they're needing 2 antihypertensives and still hypertensive, you kind of call time on it then and just deliver the lady. But occasionally we do use methyl dopa if someone is, say, for example, is severely asthmatic, and then they also can't tolerate nifedipine. Sometimes nifedipine can give people quite a few side effects and they really don't like taking it. So these are the patients that might get methyl dopa, really. Basically, they can't take the other 2 at the same time. So I've talked about how you can be mild preeclampsia, which is basically just that definition I said before, the higher blood pressure above 140/90 with some protein. Just is a definition of preeclampsia, but of course it can be more severe. Generally, by the time you get symptoms, you're already in the more severe end of the spectrum. But this is the official definition of severe preeclampsia. I didn't spell that right. So either you have very high blood pressure, so above 160, 110, with 1 loss of protein, or you have moderate hypertension, so systolic above 140 and diastolic above 90, with 2+ or more protein, or a PCR of above 30. And as well, you have to have symptoms as well. Some symptoms, so either severe headache with visual disturbance, right upper quadrant pain, more than 3 beats of clonus, platelets less than 100, or an ALT of more than 70. So, there's different ways you can be diagnosed, essentially. If you have very high blood pressure, you don't have to really have the symptoms, though they almost certainly will have the symptoms if their blood pressure is that high. Or you can have slightly less high blood pressure, but other things going wrong. So, if you're an A&E or a GP and you've found somebody with blood pressure that's high, who's pregnant, and you're like, okay, what do I do now? I've discovered this blood pressure. I've done very well. I have ignored the news, and I've seen that she has high blood pressure. So the key thing with a pregnant woman who's above 20 weeks is to check the BP reading properly, as in actually check the number, rather than just she's scoring 0, which is fine. Normally that means she's fine. But it's important to actually check the actual number, because as I said before, 140/90 won't score on the general adult news. In maternity, we use a special maternity early warning score, which it would score for. But obviously, if you're an A&E or a GP, you're not going to be using that. So it's important to actually check the actual numbers when you see a pregnant lady, rather than just go with the news score. If you see that it is above 140/90, to be honest, a lot of people's blood pressure is above 140/90 when they first arrive at A&E, and also with the machines as well. Very often it is more than that. But if you recheck it, give them time to calm down from the whole, just arriving in A&E, and ideally do it manually if possible. In GP, that's probably is possible, but I'm not sure in A&E if you have any manual blood pressure cuffs, and I don't know, but ideally do manually, but it is okay with the machine if that's all you've got. Check urine dip for protein. Ask for the preeclampsia specific symptoms. So I think if you saw someone with epigastric pain, you wouldn't necessarily ask them if they have a headache. So you can ask that as well. If the blood pressure is still raised and there is some protein, then refer to obstetrics, basically. If the blood pressure is raised, even if there is no protein, I would still call obstetrics anyway. That's fine. I'm perfectly happy to see them. As I said, quite often the blood pressure is raised in A&E, but when they come up to maternity triage, it's settled down, and then we don't need to do anything more, which is fine. But I'd rather do that than not do that, and there'd be someone with preeclampsia walking around out there. So I put this one in because some of you might be OBGYN SHOs, like the F2s rotating through, or GP trainees rotating through. So you might actually see them on maternity triage. You might actually be the one seeing them on maternity triage. So I've kind of done it from that angle as well. So again, the specific history. So it's mostly headache, visual disturbance, epigastric pain. But you can ask them about like facial swelling or hand swelling. Now, obviously today that would not be a very relevant question on a really hot day, but sometimes they might tell you, they'll always tell you that their feet are swollen, but feet are always swollen when they're pregnant. So that is not a good sign of preeclampsia at all. But hand swelling, having to remove rings, or like the partner, for example, saying that their face does look more swollen, can be a good sign. When you see someone who has really true severe preeclampsia, they quite often are very swollen in the face. I saw a lady in clinic who she was definitely she was severe preeclampsia. From the get-go, I referred her into, this was in clinic, so I sent her to the labor ward. And then I happened to see her on labor ward the next day because I was on call the next day. And you could see the difference in how much swelling she had on her face. She was unrecognizable almost how much swelling she had. So partners sometimes do pick up on that and say her face is really swollen. So that can help as well. So another thing to add to your examination would be, obviously you're going to do an abdominal examination on a pregnant woman anyway. But reflexes and clonus, that's not something you routinely do on anybody really, but especially a pregnant person. But it's something you could do if you see them in the maternity triage. When we see them on maternity, we don't just take one blood pressure reading, we take 3 readings, 15 minutes apart, and we usually ignore the first reading as well for exactly the reasons I said. When someone first arrives, very stressed, it's a big whole thing, so their blood pressure often is a bit higher. So for us to diagnose as preeclampsia, I would take the lowest of 3 readings, and if that is still above the threshold, then I'd count that as high blood pressure. Doing urine dip. If you're on maternity triage and there's more than 1 plus of protein, then a urine PCR should be sent. If those things are both true, then this lady is going to be admitted essentially. So you need to put cannula in and do bloods. And these bloods here are what we do as routine, or what we call preeclampsia bloods, because essentially it's looking for help. That's what that is for, really. Plus, we do UNE because they can go into renal failure to have severe preeclampsia. Someone who has preeclampsia should have a CTG, but honestly, as an OBGYN, you'll never have to ask a midwife to do an CTG. They do them on everyone. Everyone gets a CTG. You walk in the door, if you're pregnant, you get a CTG. So it's very unlikely you're going to have to ask a midwife to do that. They also mostly routinely send the PCR without you having to ask them to do that as well. They're very good at managing blood pressure. To be honest with you, if a midwife sees someone with high blood pressure, they're most likely just going to immediately just call the registrar rather than call the SHO. But just if you did happen to see them, this is just what you should do. If you see someone with blood pressure and protein, you should always discuss this with the senior, either registrar or consultant, whoever's around. So just more for just a background, you don't need to know this, but I just thought people might be interested just to know what we do next when we have preeclamptic ladies. So as a senior, what we're going to do is we're going to admit them to the labour ward for HDU care. You give them, obviously, you need to bring the blood pressure down. It's the most important thing. So we normally start with the oral hypertensive stats, normally labetalol, so we can give that again if we need to. But if it's not improving after 2 oral hypertensives, we can consider giving IV antihypertensives. Again, normally labetalol, or if they can't have that, hydralazine. If they are needing IV, or if we think, they're very severe preeclampsia, then they should have magnesium sulfate, which is for neuroprotection for themselves and to prevent fits, essentially, prevent eclampsia. It does also bring the blood pressure down a little, but only a little bit. We're not really using it for that. But it's more for neuroprotection and to prevent fits. Someone with severe preeclampsia should be fluid restricted. As I said, they're very leaky. They're like someone in heart failure. You would fluid restrict them. And yeah, so as part of that, you're probably going to put a catheter in so you can have an accurate monitor of urine output. So if they're very severe, they have bloods every 6 hours because they can really deteriorate very quickly, especially if they're needing IV antihypertensives, or if they're on magnesium sulfate, they definitely would be having 6-hourly bloods. If they're not as severe as that, then they might have 12-hourly bloods or daily bloods, depending. If they're outpatient, they usually have twice weekly or weekly bloods. So it kind of just depends how severe they are. But if they're inpatient and on all of these IV medications, then we'll be doing 6-hourly bloods on them. And we should consider delivery. If they're that severe, we should consider delivery, even if they're very early. If they are that severe, the cure for preeclampsia is to deliver the baby. So that's what we have to do. And the mother always comes first. So even if the baby's very preterm, if the mother is that severely hypertensive, we don't have to have a stroke or something like that. That's obviously much worse. So if we're considering delivery, we would give the baby steroids as well. So just to finish off this case of this lady, so she did get admitted to labour ward. She was managed with oral antihypertensive, so she didn't need to have IV. She was on mag sulfo. The bloods. So if you remember, the bloods that she had in A&E were normal. Although when you actually look at them, you could see a downward trend, but they were still in normal range. But 6 hours later, her platelets are 95, ALT was 65, HB 101, and clotting and urine were normal. However, because she has low platelets and elevated liver enzymes, that's help. Her HB was around that before. That hadn't dropped massively, but it's quite normal to be anemic in pregnancy, so that no one had really thought anything of that, and I wouldn't also think much of that either. 101 is not too bad really in pregnancy, but yeah, it's more the platelets and the ALT. As I say, they were normal 6 hours later, so you can see how quickly they can deteriorate. So she had magnesium sulfate and she had steroids for the baby. She's in 29 weeks, if you remember. And she had a cesarean section the following day. And yeah, she got better after that. That's fine. I don't know what. I'm sure the baby was okay as well, but I don't actually know if it was. I'm sure it would be all right. It's very good these days in neonatal unit. So, preeclampsia key points for the non-obstetrician. Hypertension in pregnancy does not score on the adult news. So if the pregnant patient is over 20 weeks, look at the actual number, not just the score. I'm not sure if it would have changed much, but as I said, when you look back, the blood pressure was actually above the 140/90 both of the time, or all of the times that she came to A&E. So, could have potentially found it a little bit earlier. I doubt it would have changed any of the outcome, to be honest. As I said, when they get it that early, they're usually very severe anyway. If it's high, repeat it, ideally manually. Always a urine dip if you're pregnant, even if there are any symptoms. Not just for protein, but for urine infection, things like this. They can often be asymptomatic. So it's always important to dip urine in pregnant women. And refer to us, or if you're already ONG, refer to a senior ONG. And do it early if blood pressure is raised, as they can deteriorate very quickly. So that's case 1. So moving on to case 2. They're not all as intense as that. I'm still going to probably finish at 8 o'clock. That was just the biggest one, because preeclampsia is very common. It's something in the region of like 3 to 4% of pregnancies. So it's common. The rest of the things are very more rare, but they're just, important to find if you see them, important to find. So that's why I spent most of the time on that one. Case 2. So again, this is a real case. It happened at a hospital, not in Northwest, but in Wales, in rural Wales. And it didn't happen while I was working there, but the repercussions were felt from it. And it is a real case. So she was 33 years old, first pregnancy, normal BMI. She had a history of a DVT following, I can't remember what, she had some kind of minor surgery and appendix out, something like that. And she had a DVT following that. But otherwise, she was fit and well. She wasn't on any long-term anticoagulants or anything like that. She just had a history of a DVT. So she went to the gynae assessment unit around 7 weeks from her LMP with PV bleeding and abdo pain, so it was a suspected miscarriage. She came back the next day, that was fine, a bleeding settled, a pain settled, so there's no more concerns from that side of things. And yeah, the pregnancy was viable in uterine pregnancy. So she was advised to book in with the community midwife, and she was discharged from the early pregnancy unit. The VT risk assessment was not documented at the time. When about a week later, she had a booking appointment with a community midwife. The community midwife did write down that the lady had a previous DVT in the booking documentation. The midwife arranged a dating scan and a clinic appointment with a consultant at 12 weeks following the dating scan to discuss the previous DVT and what that would mean for her pregnancy. 3 days later, she went to her GP. She had mild shortness of breath. I don't know if it's really relevant, but it was sort of mentioned in the case, so I guess I'll mention it as well. It was middle of July, very similar weather to now. It's very, very hot. So basically the GP wasn't really that worried, reassured the patient, did kind of tell her it's probably just because you're really hot. So, just like drink plenty, that kind of thing. And everything else was fine. Her examination was fine. Everything was okay. So he just reassured her. The GP did not ask about if she had a previous VTE, and he did not check the medical records. At 10 weeks and 6 days, so a couple of weeks later, patient collapsed at home. Partner rang the ambulance. This is rural Wales, as I mentioned. So she went to the hospital by ambulance, but then she was airlifted to the tertiary centre in Cardiff, but she never regained consciousness. And 3 days later, the life support was withdrawn. So when she had an autopsy, the cause of death was hypoxic brain injury caused by cardiac arrest as a result of bilateral PE. So as we talked about before, kind of was hinting that way in the first one. PE is very important. Cause of death in pregnancy and cause of obviously morbidity as well in pregnancy. It's always important to consider. As I say, I think that most of the time we're very good actually at considering PE and considering VTE in pregnant ladies. We definitely over investigate, but it's better to over investigate than under investigate. So VTE, so that's including DVT as well, is 10 times more common in a pregnant than a non-pregnant woman of the same age. So these are the numbers, and of course it gets more likely to happen if you get older as well. So I don't know if anyone has worked in Embrace in obstetrics in the UK. You would hear a lot about Embrace and whatever. So Embrace is basically a report that's made every year about the pregnant patients that have died in the last 3 years. So it goes through all the deaths in someone who was pregnant or who was postpartum, and just sort of analyzes why these ladies died. So thrombosis and thromboembolism is the leading direct cause of maternal death. So when we think about maternal death as well, we also think about direct. So that's something that basically the pregnancy has caused that woman to die. And then we can think about indirect causes as well. So indirect cause would be, it wasn't the pregnancy itself that caused the woman to die, but the pregnancy exacerbated that problem. So something like epilepsy is indirect because if they die of sudden death in epilepsy while they're pregnant, they didn't die because they were pregnant, but their pregnancy probably made epilepsy worse. Anyway, that's an aside really. Basically, it's the leading cause of death in of direct cause of death. So it is important. 20 women died in those 3 years. Obviously, not very many pregnant women die in general. As you can see, that's the leading cause, and that was 20 women. So it's not very many, but still, we don't want no pregnant woman should die, really. they're young women, they shouldn't die in pregnancy. So basically, all pregnant women are high risk of VTE. I feel like I've already talked about this. And you should have a low threshold for suspecting and investigating VTE. So as an aside, everyone should have a VTE, all pregnant women should have a VTE assessment done at booking. And depending on their risk, some of them might have low molecular weight heparin. Prophylaxis throughout the pregnancy was starting from 28 weeks. And that was the big thing coming out of the case that I talked about. Essentially, that woman, having had a previous VTE, should have been on prophylaxis as soon as she was confirmed a viable pregnancy. So she should have been on it from 7 weeks or whenever it was she had a scan. If we know they have a previous VTE, they should really have an early scan so that we can start the prophylaxis as early as possible. So that was the big, what came out of that case. It was a really big deal at the time because, basically that woman shouldn't have died. She should have been on prophylaxis, and also the GP should have considered referring for investigation of a PE as well. But yeah, depending on your risk, they either start right at the beginning or some of them start from 28 weeks. VTE risk is even higher postnatal, so you have to have an even higher index of suspicion if they recently had a baby within 6 weeks. This is the very prime time for VTE. And a lot of women score for the prophylaxis postnatally, even though they didn't score antenatally. So we have I'd say most women go home with at least 10 days of Clexane. So if you see them in A&E, if they've just had a baby like a week ago, definitely you need to suspect a PE or a VT or a DVT. So in terms of how you would manage them in A&E or in GP, investigating a DVT is exactly the same as if they're not pregnant, apart from don't do D-dimer, no D-dimers, just they're high risk, don't bother with all that. Just you suspect it, they're high risk already, just do the Dopplers and give them the treatment dose while you're waiting for the Dopplers. So if you think PE, there's a debate about CTPA versus VQ for a pregnant woman. So basically, CTPA, there's a very small increased risk of maternal breast cancer in the future from the radiation. If you have a VQ scan, there's a very small increased risk of childhood cancer for the baby. And that, to be honest, I should have put very, very small because that is a very much smaller risk than the risk of the breast cancer. It's very, very, very tiny. We're talking something like 0.0003 or something percent. It's really small. But yeah, it's there, I guess. However, both of them, the amount of radiation that they deliver are below the threshold for safe amount of radiation in the pregnancy. So they're both completely fine to do in pregnancy, and you should definitely do them if you suspect a PE. Normally, in my experience, it's CTPA, basically VQ should be first line, but most units won't do VQ. So you'll have CTPA because VQ is quite difficult to get hold of, especially out of hours, almost impossible. So most women will have a CTPA, you don't really have a choice, but essentially you can do either, and VQ is probably better. Just briefly on the radiation in pregnancy, there's no, studies, obviously, because you can't really study that. But essentially, a woman can have a CT thorax abdo-pelvis during her pregnancy and still be below the amount of radiation in there, safe amount of radiation. So, you should definitely do the scan if you need to do the scan. Same with if they need to have a CT head, they should definitely just have it. And, sometimes the delay waiting for like MRI head and stuff, it's not worth it. Like, just do CT if that's what they need to have. And of course, always risk benefit, isn't it? So, we have to always think about that. So, other key points for VTE in pregnancy. Generally, when we give treatment dose to the pregnant lady, we give it as BD dose and base it on their booking weight, not their current weight. You can give it once daily. I don't really know why we do BD, but we can't. It generally is BD. If they are diagnosed with a PE or a DVT in pregnancy, they will have their Clexane throughout the pregnancy, even if they're only 8 weeks, they will have it for their whole pregnancy, and they will have it for at least 6 weeks after they've delivered the baby as well. If they got their PE when they were 36 weeks, then they'll have it for 3 months in total, as long as it's 3 months in total, then they might have to continue it after the 6 weeks postnatally as well. So they just need at least 3 months, and they definitely need to be on it all through the pregnancy. If you have a massive PE, thrombolysis is safe if they need to have it. Unfractionated heparin is also safe if they need to have it. And yeah, postnatally, so antenatally, it's always low molecular weight heparin, unfortunately. So they have to inject. Warfarin definitely unsafe in pregnancy, and the newer anticoagulants, there's just not enough evidence to say one way or another, so we don't use them in pregnancy. But postnatally, they can change to an oral anticoagulant, and it depends if they're breastfeeding or not. So if they're breastfeeding, they can have warfarin, that's fine. But they can't have, again, we just don't have enough evidence yet for the newer ones, so we generally avoid them. I suspect they will be safe, but we don't know that yet. So generally, if they're breastfeeding, they'll have warfarin. If they want to change to an oral, or they continue with low molecular weight heparin if they want to do that. Or if they're not breastfeeding, they can change like apixaban or whatever. I've got a few questions. Are patients given the choice between the two investigations? Sometimes, some units, they do get the choice, but to be honest, a lot of the time, the choice is made by the radiologist who's like, well, I'm doing a VQ scan. That's generally. But if they do have the choice, then yes, we do discuss the risk with them and give them the choice. We should discuss the risk with them anyway, but yeah, just about the potential risks that there is in the pregnancy, to the pregnancy and to themselves for the longer term. But also the risk, potential risk of not diagnosing a PE is essentially or they just have to stay on the treatment dose if we're not going to do, basically if we're not going to do a scan, they just have to stay on the treatment dose. So if they'd rather do that, then that's fine, they can do that. That's fine. But most people don't want to do that, to be honest. Right, so that's DTE, bit quick, and the rest are going to be even quicker because as I say, we're getting much rarer now. So next lady is 38 years old. She's a gravid 2 para 1. She is 35 weeks. She's normally fit and well, low risk pregnancy, all midwife led. So she goes to A&E with right upper quadrant / epigastric pain, kind of all across the top, really. Nausea and vomiting, fatigue, and feeling generally unwell for 2 days. So, what differentials have we got from that? It's pretty vague, isn't it? Yeah, preeclampsia. Yeah, we've learned from this talk. Yeah, PE as well. Yeah, these two. All my women are presenting the same. I didn't kind of realize that until now, but they are kind of all. Yeah, you definitely need more history, obviously. Yeah, this is not very, this is very much you read it on the line in A&E, the top line of what she's come with. Yeah, liver disease. Cholecystitis, yeah. We have to think of things that are not pregnancy as well, not everybody is going to have preeclampsia. If they've got right upper quadrant pain and vomiting, or, you'd normally go for gallbladder of some kind or liver disease of some kind. Yeah, or lower lobe pneumonia. Yeah, hyperemesis is a bit unusual at 35 weeks, but, yeah, like gastroenteritis or something like that. Torsion, I'm not sure what torsion you mean. Yeah, pancreatitis, yeah, that's another one to definitely not miss. Yeah, anyway, so basically there's loads. That's the summary. It could be anything from that. You need follow-up on history and everything else. So yeah, it could be heartburn, an ulcer, gastroenteritis, gallstones, pancreatitis, hepatitis. Just generally a viral infection, just generally feeling run down. Yeah, any kind of ACS, PE, preeclampsia, etc., etc. Goes on and on and on. So this lady on examination generally was unremarkable. She's slightly tender in the upper abdomen, but that was it. She's pregnant, obviously. So these are her bloods. So white cells slightly raised, platelets a bit down, each, a bit anemic, but that's quite normal for pregnancy. I wouldn't be that worried about that. So ALP is high, but it's always high in pregnancy, so that's normal. But her ALT is also high, and her bilirubin is also high. Yeah, those are fine. But creatinine's raised and urea's raised. Amylase was normal. Glucose is a little bit low. And these are prolonged. I didn't know the reference ranges either, but they are prolonged. So, if we're looking at these bloods now, she's come with upper abdo pain. She's got deranged LFTs. She's got the deranged uni, deranged clotting. White cells are slightly up, platelets slightly down. So what do we think this could be? Do they help at all, these bloods, really? So yeah, definitely could still be help. Yeah, I agree with that. Yeah, not really obstetric cholestasis. You don't really get deranged uni with that. Not really. But, and you don't tend to really get deranged bilirubin with obscoli either, usually. But yeah, basically, it's very specific, so you probably wouldn't know this. But looking at it, you see she's obviously got some kind of liver problem because she's got deranged clotting as well. So that's concerning for something like a liver pathology. She does have, a kidney injury as well. It's hard, just from that you don't really know if that's come from the liver failure or from the, what's causing what. But basically, this is acute fatty liver pregnancy. This is the only non-real case, because I've never seen this, because this is very, very rare. I haven't seen this, but it's an important thing to pick up if you do see someone with deranged LFTs who's pregnant, also with deranged UNE. It's very important to refer and consider this as a differential. It's often a very vague presentation, especially at the beginning. They're often just fatigued, a bit run down, a bit of epigastric pain, very vague, very pregnancy symptoms, to be honest. The vast majority of people who present like that have absolutely nothing wrong with them. However, they do deteriorate very quickly. So generally they'll progress to acute liver failure within about 1 or 2 weeks. So it's very quick deterioration. So the first time they come, you might not get it, which is fair. But then when they come back the next time, you see the bloods and you'll be like, something is definitely wrong here, because they will deteriorate very quickly. It's like proper acute liver failure, jaundice with hyperglycemia, coagulopathy, ascites, encephalopathy, and acute kidney failure. So 90% of them get all of those things within 1 or 2 weeks. So it's very quick deterioration. So as people rightly pointed out, it can present very similarly to preeclampsia, including with raised blood pressure and proteinuria as well. And the blood derangement is very similar to HELP initially as well. So a lot of the time, that is kind of the route we go down first, which makes sense because preeclampsia is like 4% of pregnancies rather than 0.005%. But the key difference, if you want to think what is the difference here, is a hyperglycemia. You do not get hyperglycemia with preeclampsia. So if you see someone who's also hyperglycemic, that should make you think about acute fatty liver pregnancy. So how is it managed? It basically is life-threatening. You can imagine it's liver failure, so it's life-threatening, and they deteriorate so quickly. It's mostly supportive, but they often need to go to ITU. As you can imagine, they've got multi-organ failure essentially. Early delivery is the real treatment, because again, it's pregnancy related, so it often resolves completely after they are delivered. Complete recovery with no long-term sequelae often if you do it early enough. Of course, if they have more lasting liver damage, they might have to go through the normal acute liver failure, long-term problems, having and have like liver transplant, things like that. But that's not very usual. If you deliver the baby, usually they will recover completely. So, I mean, I'm not expecting anyone in A&E to really kind of find that diagnosis. I think I wouldn't even find this diagnosis on maternity triage. But basically, the key point for someone who's a non-obstetrician is if you have a pregnant woman in your A&E or your GP that has deranged blood, just discuss it with us, and then we'll decide what we think. At the very least, someone with deranged liver function like that, with any kind of deranged liver function, we would want to follow up in the clinic. We would, something like obs-colly, which someone mentioned, obstetric cholestasis that someone mentioned, we would see them weekly in clinic. So, even if it's only just the ALT that is raised, we would want to know about these people, and we would see them in the clinic. So that's probably how we would pick it up, because we would be repeating their bloods every week. So that's that one. Case 4, which is the last case. So she's 35-year-old. Here's her first pregnancy. She's also 35 weeks. She's low risk pregnancy, no medical problems. This is a real case, not one that I've seen myself personally, but it's a real case. So she went to her local A&E on a Saturday evening with shortness of breath, palpitations, and coughing up frothy pink sputum. She was very anxious as well. On examination, blood pressure was okay. She was tachycardic and tachypneic, and she had low SATs. On examination, she had reduced air entry at the base of the right lung. So what's the differentials with this one? And all chest, I've just realised. Chest and upper abdomen. Never mind. Yeah, lower lobe pneumonia, yep. I mean, I'm sure someone's going to say PE as well, because it could be PE. Yeah. TB, yeah, that's really out of the left field. I guess if you're in London or somewhere like that. I work in Wigan, so no one has TB in Wigan, so. But yeah, anyway, basically, something lung, we're thinking, right? Or PE, which makes sense. So that is exactly what they thought. So she was admitted under the medics. So their differentials were chest infection or PE, or just a panic attack generally. But I think she did have low SATs. So even if it was a panic attack, fair enough, they admitted her. Lung malignancy, well, yeah, I guess it could be. Yeah. Pregnant, that's another thing to think about. Pregnant women do still get cancer, they do still get everything else, especially breast cancer, things like this still happen in pregnancy. So yeah, it could be like a MET from a breast cancer or something like that. So that's a very good out left field thought, but we should think about it. At least, do a chest x-ray. So I don't really know why. There's nothing mentioned about a chest x-ray. So I assume that she did have a chest x-ray, but it was probably normal. Anyway, so they kind of went down the route of PE. So they did order a CTPA, but it was Saturday. And the radiologist said, no, not doing that out of hours. She can have it on Monday, which is quite standard in a DDH. I've experienced that as well. Because they say, well, she's on the treatment dose clexane, so it doesn't really matter if we do the CTPA, which is fair enough. So she was to start on antibiotics for chest infection anyway, and given treatment dose clexane as well. So it didn't really get better, and actually she started needing a bit more oxygen, if anything. When they did the ward round the following morning, the patient complains she had to sleep in the chair all night because she couldn't breathe when she was lying down. So through Sunday, she just got worse and worse and worse, and then she had a cardiac arrest in the early hours of the Monday morning. She had a perimortem section as part of resuscitation. The baby was fine. That was not an issue. So that is something that we would do if someone has if a pregnant lady is over 20 weeks and she has a cardiac arrest. If there's no return of spontaneous circulation within 3 minutes, we should do a perimortem section, which basically just means, it's not for the baby, it's for the mum, it's part of the resuscitation. Essentially, the uterus is putting a lot of pressure on the the aorta and the vena cava, and also, the body is also trying to supply a baby with blood as well, which really is the least of its worries at that moment. So we would do a perimortem section to help with the resuscitation of the mom, not to save the baby. So it does help it does improve outcomes for pregnant women who have cardiac arrest. Again, this is very rare to have cardiac arrest as a pregnant woman, but if it does happen. So once she'd had the perimortem section, she was resuscitated and she had ROSC, and then obviously she went to ITU after that. She was reviewed by a cardiologist and they did an echo, which showed a severely reduced ventricular function, essentially. So despite ITU management, patient became increasingly unstable and died later that day. So sorry, these are really depressing stories, but basically the key thing is to think about cardiac disease in pregnancy. We think about PE. I think we're quite good at thinking about PE. We think about chest infection, things like all these more, things that are common. We don't really think of young people having cardiac disease, and they don't most of the time, obviously. But it's important to consider cardiac disease in pregnancy, especially cardiomyopathy. A lot of women have been completely fit and well, and then pregnancy is a real stress on the body. So when they become pregnant, these underlying conditions can surface, basically. So again, this is all from Embrace. That story is from Embrace. They have little stories of women who died, because it's not that many, so they can just write them all down, basically. But this is one of the women who died. So cardiac disease is the #1 indirect cause of maternal death. So as I said before, that basically means it wasn't the pregnancy itself that caused the death. It was, heart failure that caused the death, but the pregnancy made it worse. And actually, cardiac disease is the #1 overall cause of death as well. So it kills more women than from VTE, mostly because of being undiagnosed and people missing it, really, because also is more difficult to manage. Someone in severe heart failure, that is a lot more difficult to manage than someone with PE, basically. That's another reason as well. So in that time, there was 36 deaths. As you can see, that was more than the VTE, which was 20 deaths in those 3 years. So it does seem to be increasing as well. This is probably because we're getting a lot of people getting pregnant when they're older. That shift towards having babies in your 30s and even in your 40s, not that unusual to have a baby in your early 40s now. Also, of course, increasing levels of obesity and other bad risk factors for cardiac disease. And of course, another thing is that we see that people who were born with congenital heart defects, who in the past wouldn't have survived to the age where they could have a baby themselves, have actually survived and are having their own babies now. So if they already have an underlying condition, obviously they're more likely to, that's more likely to be exacerbated in a pregnancy. As I said, most women had no previous history of any cardiac conditions, so they didn't know they had a cardiac problem. 17% of the women who died from cardiac disease did know they had a cardiac condition already, but 77 had no previous history. So it's an important thing to suspect if you have any doubt or any consideration of it, really. So how do women who have cardiac death, I mean, it's very vague, isn't it? So what do they actually die of? So they have arrhythmias, or they have cardiomyopathy. These are the most common reasons for death in pregnancy. They can also have MI as well, something we don't think about in young women, but that's why we should be doing ECGs on them as well still, if they have chest pain. Other cardiac causes, so if they have a valvular heart disease, usually the ladies already know they have that, but they can die from it from pregnancy. There are certain heart diseases, that are advised to never get pregnant, but sometimes they decide that they want to try anyway. And also aorta dissection is an important one not to miss in pregnancy. You will not expect that, but obviously it can happen. And they can have coronary artery dissection as well. So actually, most of the deaths are postnatal rather than antenatal. So I think if we saw a pregnant woman, we're all very worried about her. Whereas if we see someone who had a baby 3 months ago, we're not really that bothered about that. That's like, well, she's just a normal woman, right? She's just a woman, a young woman. Which, to be fair, I would have also thought, yeah, and I do kind of think, but the majority, we should think about cardiac disease in people who are postnatal as well. So when you actually get the breakdown of the deaths, or the women who died from cardiac disease from pregnancy, only 15% were actually antenatal, 21% are on the day of delivery. Can you imagine that's a high stress day, isn't it? 34% were between day 1 and 6 weeks, so that's the real danger time, is immediately postnatal. However, 30% still were between 6 weeks and 1 year postnatal, so that's still a very dangerous time for a woman who's been recently pregnant with cardiac disease. So basically, if you see someone who is recently postnatal and they come with palpitations or other signs of cardiac disease, then it's important to just consider a cardiac cause as well. Of course, most of them won't have this. It's still quite a rare thing, but you just sort of should flick through your mind, maybe. So the key points. Obviously, all women who have known to have a cardiac condition should be referred to cardiology during pregnancy. That's obvious. But basically, cardiac disease should always be a differential in a pregnant patient or a recently postnatal patient, essentially who has symptoms of PE or any other kind of chest symptom, especially if other differentials are ruled out. So it's fair enough to go down the PE route first, fair enough. But if the CTPA is negative and the patient is still quite symptomatic, then we should consider doing an echo as well. Echo is easy to do, relatively, as outpatient, it doesn't have to be inpatient. And if the echo is normal as well, then we can be fully reassured that there's nothing wrong with her. And we can just say, okay, fine, it is reflux then, or it is muscular. But really, if we're going to go down the whole route enough, if we're worried enough to do a CTPA, we should also be worried enough to do an echo. That's the key take-home point from this. So, this is the last slide, just a very quick go through other things that as an OBGYN reg I'd want to know about if you see a pregnant person in your A&E or GP. So generally, I like to just know if there's any pregnant person admitted to hospital, if they're more than 24 weeks. I'm not really that interested if they're only 5 weeks or whatever. But if they're above viability, basically, we should let us know, because we would generally send a midwife to monitor the baby daily while they're admitted. And of course, we've talked about VTE. Any pregnant patient who's admitted to hospital should always have Clexane unless they're about to go for an operation. So if at the very least, let us know and we can at least remind you about that. If you see a pregnant patient that has any kind of deranged bloods, mostly things like LFTs, UNE or clotting, pregnant women have deranged FBC all the time. So, that's just pretty normal. But, LFTs and UNE and clotting, if that's deranged, I would like to know about that, please. If they come to you with itching without a rash, especially if it's on the palms of or soles of their feet, so that's a sign of obstetric cholestasis. That's why, we'd like to see them. Be honest, most of these people come to us anyway because all pregnant women get given like this folder that just says all the red flags for them to look for, and this is one of them, so they usually self-refer anyway. If you see a pregnant woman who has definitely got chickenpox, we want to know about that, just because the baby needs to have some scans if she's had chickenpox during the pregnancy. We want to know. She doesn't have to come in. I just like to know about her, just tell me and I'll write her details down and I'll arrange a scan for her. Any kind of newly diagnosed medical condition during pregnancy. So anything like, Crohn's disease or thyroid disease or whatever, something like that. Not like an acute episode necessarily, but like some kind of long-term medical problem that's been diagnosed. It's always good to know because we will see her in our clinic if that's the case. Obviously, any obstetric concerns, just tell me. I'm sure you would always ring us about that anyway, reduced movements, things like that. And basically, if you're worried about a pregnant patient, I'd rather you just call me and we have a chat about it, and I can tell you it's fine, don't worry, and then that's fine. I'd rather hear about it and not need to do anything than you just not refer, and there'll be something wrong. So, any questions about that? So it's a bit like a random scattergun things, but I just thought it was quite interesting things that you might not think about in a pregnant woman that might be concerning. So, yeah, any questions about anything? I'm glad it was helpful. So yeah, my key take-home point is do an echo and give them Flexane, I don't know. Check the blood pressure.
Thank you, everyone, and thank you, Helen. And if everyone could just fill out the feedback form for Helen, that would be really, really useful. And if there's any more questions, we'll just wait on a bit more. And if there ain't, then thank you very much, Helen.
No worries.
I guess there's no more questions.
I'm sorry, look at that. Let me unshare that. Great, yeah, so I'm happy to share the slides if people want the slides. A lot of it's from that Embrace report, which you can just Google. It's like free to access. So if you want to, like, those are basically the things that women die from in pregnancy. So they're obviously the biggest red flags, but there is other things in there as well that is quite useful.
I guess there's no more questions. So thank you very much, Helen, and I hope everyone have a good week ahead. Thank you.
All right, thank you.
Bye.
Bye.